my name is Greer Schneider, and I'm 10 months post-operative open heart surgery for an aortic aneurysm repair, and I am an aortic athlete.
Hi, my name is Jack Crow. I am 5 years post dissection, and I am an aortic athlete too. Greer, welcome back as to interviewing for these aortic athlete presentations.
Well, thank you. It is so good to be back. Jack, a little birdie told me that you went on a little bit of a bicycle ride recently.
I did. I'm a recovering Ironman in 5 years stable post dissection, and I rode my bike from by Lake Superior down to Chicago, almost 500 miles over 6 days. But uh, my heart rate average was 92. So all zone one, zone two, really low, moderate activity that I built up little by little by little over time. And I had a great time.
Well, that does sound like a lot of miles. Does your doctor know?
Well, I had my check-in with Frank Caputo, Dr. Frank Caputo at head of vascular surgery at Cleveland Clinic. Shortly after the CT was stable and echo and everything like that, I told him what I did. And with my wife listening, he said, keep doing whatever you're doing. So I take that as, some comfort that I can keep doing a lot of lower heart rate stuff. Not that everybody should, obviously, post dissection. We're all individual, um, but uh, but it was a great thing to do.
That's fantastic. Before we introduce our guest, Dr. Eagle, why don't I just ask everyone to please remember to like this video in YouTube. Also, if you could follow Aortic Athletes and Aortic Hope, both on Facebook and Instagram. There's a lot of good information that we share. And finally, very important, this is for educational purposes only. We should all consult with our own cardiologists. Each one of us are different, but this is for learning purposes and to become a bit more educated. So Jack, I'll turn it to you for the introduction.
Right. And that's why we've titled this The Personalized Approach, because we are all different. But we're so honored to have Dr. Kim Eagle, the professor of internal medicine and the director of the Frankel Cardiovascular Center at the University of Michigan in Ann Arbor. And he's focused throughout his long career on aortic disease, published hundreds and hundreds and hundreds of peer-reviewed articles, and really is a leader in the study and research and advancement of the treatment of aortic disease. He's very involved with the Marfan Foundation, and we're honored to have you as our guest, Dr. Eagle.
Good to be here.
Hey, some breaking news. Let's talk before we get to your presentation on genetics and a few other things. There's a little bit of breaking news. I'm experiencing it here in the Upper Peninsula of Michigan at the moment, and that is Canadian wildfire smoke, both in the southern part of Canada and a lot of the United States in the northern part. We're experiencing high degrees of really intense smoke. Here it smells like a campfire. I don't know about Ann Arbor. Should people with aortic disease worry about that a little bit? Should we do anything different?
Yeah, we're experiencing the same thing here, and the air quality is really bad. And I think a logical thing for us to do is to try to avoid prolonged outside air exposure right now. It's not good for any part of our body, and I think patients with any type of cardiovascular disease, I tend to say, let's stay indoors when the air quality is bad to reduce the risk of hypoxia and things that can cause.
So, I especially hear about it for asthma, cardiovascular disease. Is this a cardiovascular? This isn't a cardio disease, aortic disease, is it? So, are we that sensitive to it?
So the heart and the lungs are connected, aren't they? And so if we're exercising and the air quality is bad, and we're having any even hint of bronchospasm and or drop in the overall oxygen delivery to our cardiovascular system, it's all connected. And you might imagine that in poor air quality, the tendency for the blood pressure and or heart rate to go up higher than would be normal would be expected. So I think it's a total body situation where you say, you know what, today would be a good day for me to do my bike riding indoors.
Okay. All right. I'll take that advice. And another piece of not quite breaking news, but something that has been going on in the national press recently, and that is the death of Senator Lindsey Graham of an aortic dissection. When I think of our aortic athletes as a whole, uh, on the one hand, there are people maybe who have dissected, and this is kind of a triggering event, and it happened to him and he died, and so will it happen to me. And then on the other side uh, are people who maybe discount or underplay the risks associated with aortic disease. I'm just wondering, for you, what's your takeaway? What can we learn from when a very public figure like Senator Lindsey Graham dies of an aortic dissection?
So it's a good question, Jack, and I'm not privy to exactly how he presented and what the findings were, whether there were any warning systems. I was told that his father had sudden unexpected death. And this reminds me a little bit of a famous actor named John Ritter, who died of an aortic dissection some years ago, whose father, Tex Ritter, was also in the movie industry, had sudden unexpected death. When a family member has sudden unexpected death, the tendency for the society is to assume that it was a heart attack. And what we actually know is that about 10% of sudden unexpected death is actually caused by an aortic dissection. If you look at patients who routinely have, say, an autopsy after that happens. And so for patients with aortic disease, knowledge of family history is very important. And if there's a family member who had sudden unexpected death, one would have to assume that that could have been an aortic dissection. And that probably is a risk factor for more aggressive management and follow-up of a patient who has known aortic disease.
When I dissected, I didn't know what I now know, and that's that 5 of my 6 siblings all have aortic disease. I wish I knew that when I dissected at 4.3 centimeters out
Wow.
of the blue.
Yeah. Yeah. Well, we're so fortunate that you got great care and you're still here and living a vibrant life.
I was in rural the Upper Peninsula of Michigan, right here. I was able to access high quality cardiothoracic care about 2 hours away.
Thank
Uh,
goodness.
well, let's turn it over to you for your talk this morning, and then Greer and I will come back with some questions. And we have a bunch of questions that aortic athletes have submitted. We're very anxious to ask you a few questions.
Excellent. I'm looking forward to this. So we'll put up the first slide. And I'm just going to talk for a few minutes about precision. And we're going to talk about precision of medical care, about what we know about genetics, and what we know about patients who have aortic disease, trying to be more precise with excellent care and prevention. And this is the introduction. I think it's fair to say that there's a lot of enthusiasm and hope for improved understanding and better treatment and prevention of patients who have aortic disease who may be tuning into this broadcast. More precise care includes understanding a person's genetic risk. It understands whether or not there are biomarkers that come to bear in treatment, and also how we will use imaging more effectively as we go forward. And my talk will primarily focus on some things that I think your general audience might be interested in related to genetics. So if we can have the next slide. For many years, we were aware of just a few genetic conditions that were associated with aortic disease. And I suspect that many of the listeners to this broadcast were aware of Marfan syndrome, which we understand goes back about 50 years. And more recently, several other areas have become aware to us. One is an umbrella of diseases called Loeys-Dietz syndrome. There's something called Ehlers-Danlos syndrome, and something that happens primarily in women, Turner syndrome. So these were the first kind of four buckets of genetic abnormalities that were known 30, 40 years ago that we focused on. But as the human genome was mapped, and as we've gotten more sophisticated in our ability to look at genetic abnormalities in aortic disease, we are far more sophisticated in thinking about it. And I think the next slide will show you that. Currently, if I see a patient who I think has a familial related aortic problem, I can send out a lab test to look for about 25 different genetic abnormalities that are known to cause aortic aneurysms and/or aortic dissection. And we divide them into three different groups depending on the part of the aorta that they affect. One's called the extracellular matrix, that's ECM. One's something called TGF-beta signaling, and another is the smooth muscle cells. And as we think about the aorta, it's a tube that is full of elastic elements that allow the aorta to withstand the steady pressure and pounding that comes from each heartbeat. And now we have a list, a library, if you will, of known genes that, if abnormal, predispose a person to aortic dissection and/or aortic aneurysm. And we can look for these in family members if we find one in a particular person, something we'll call a proband. Next slide. If we look at patients who don't have Marfan syndrome, we can now actually identify the frequency of the different type of genetic abnormalities that make up the lion's share of genetic aortopathy. And this slide just illustrates that there's an army of scientists working together to try to understand the library of genetic defects that cause aortic disease. And as this science emerges, we'll be far better able to look at an individual patient and say, okay, there's a likelihood that you have a genetic abnormality. We can isolate it exactly which chromosome it's on and exactly what the abnormality is. And we'll be able to use that information in the evaluation of your care and potentially also first-degree relatives who also have that gene. The next slide, I think, illustrates another point. If we look at patients who come to the University of Michigan with an aortic dissection who are young, we find a known genetic abnormality in about 10% of them. And this slide just illustrates the different type of genes that we can now identify in that special population. Obviously, an aortic dissection in a young patient is a very dangerous problem, something we want to try to prevent. And we're looking deeper into understanding how frequently do we find a gene and which genes are they? And then how can we use that information to provide more precise care? Next slide. This looks at a group of young patients who deep dive genetics, something called whole exome sequencing, where we're able to say that about 11% of the 240 patients had a known pathologic variant in their genetic structure. And that one on the top left, the FBN1, that is the gene that particularly is related to the Marfan syndrome. I use this slide for this audience for a very important purpose, and that is something that is important just to reflect on as you consider genetic testing. When we send a patient with possible genetic aortic disease for genetic testing, we have to be prepared for what the results might be. And they may reveal what we call a pathogenic variant. That is, we know that there are other families where that particular genetic abnormality has been clearly associated with an aortic problem. However, genetics isn't perfect. And sometimes we'll find a genetic variant which is near a known pathogenic variant, and we're not sure. We don't know for sure if it's an abnormality or not. That's called a variant of unknown significance, or the VUS. And I put this slide in here to just illustrate the fact that if members of our audience go for genetic testing, the doctors and team should help them understand, listen, there's a chance we'll find a pathogen, that is a variant that we think clearly is related to your aortic problem. But at least 3 times more common is we may find a slightly abnormal gene where we just don't know yet if it's important or not. And obviously, for patients to live with that type of uncertainty can be a challenge. And so when I send a patient for genetic screening, I say there's a chance that we won't be able to say the genome is perfectly normal or perfectly abnormal. And there's this gray zone that we have to live with. Now, many of these variants of unknown significance, as we continue our quest to develop that genetic library, later will be identified as being important. But right now, there's the unknown. We're not sure. And this just simply reflects the fact that genetic testing is an inexact science right now. Let's go to the next slide. One of the things that is so wonderful about the progress we've made with the understanding genetics of aortic disease is that now specific genes are known to predispose to an aortic dissection at a different size diameter of the aorta. And what this shows you is this continuum from the left to the right, where depending on the exact gene, an aortic center may say, you know, because of your family history and this particular gene, we recommend prophylactic or preventive surgery of your ascending aorta to try to prevent a dissection. This is a much different sort of thought than we had even 10 years ago, where we primarily thought we wait for the aorta to get to 5 or 5.5 centimeters in diameter before we repair it. Now we know there are certain genes that predispose to aortic tear or rupture at a much smaller size than 5, where we recommend in aortic centers of excellence that they be considered for prophylactic or preventive ascending aortic repair. And the next slide. So this slide simply illustrates that now aortic centers like the one I work in, we have specific cut points for different genetic abnormalities that run in families to help us be much more precise, especially to prevent aortic dissection in a patient who's thought to be at particular risk because of the specific gene that they have. Next slide. If we think about the yield currently of genetic testing, it's far from perfect. You know, if I look at a patient who absolutely looks like they have, say, Marfan syndrome with the features that are typical of that type of a problem, the skeletal features, the eye features, the heart features, we still only have a yield of genetic testing of about 90% when we test them, even though we know they have it. And this illustrates the fact that the genetic testing is imprecise. If the genetic testing is trying to look for a specific change in a gene, but it is not able to identify a duplication or a deletion of a gene, then we might miss it. In patients who we encounter who have aortic disease that clearly seems to run in families, where multiple members of the family, like you, Jack, are affected, we'll find a known pathogenic genetic abnormality in about a third so far. But that genetic library is growing, and I expect that that number will increase as we get better. In patients who are young, who dissect under the age of 55, we will find a known pathogen in about 10%. I think that number is high enough that I test everybody for a known genetic defect, because if we find it, then we're going to suggest that all of their first-degree relatives will have genetic testing to see if they have the same gene. And if they do, that can be life-changing. We really want to watch them for the development of aortic disease and do everything we can to prevent them from having an aneurysm and or an aortic dissection. Next slide. So we'll do testing in patients who have syndromic features that we talked about if they're young, and if there's a family history of aortic or peripheral artery or intracranial aneurysms. And if there's a family history of sudden cardiac death in patients who are young. Those patients, we have to wonder if they might have not a coronary problem, but an aortic dissection. John Ritter's story, Lindsey Graham's story, fathers who had sudden unexpected death. In retrospect, if we had thought about aortic disease, then screening might have led to a better outcome for both of those men. Next slide. Next slide. Okay, good. So hopefully that's a brief overview of kind of where we're at today with genetics. It's an exciting field because it's moving virtually every month. New genes are being discovered, and their relationship to aortic disease is being connected. And the future for more precise care, I think, is really bright for members of this audience.
Well,
I have a question right
go ahead,
away. That was actually the first time I saw the gene with the different centimeters associated with it. We have had some of the cardiologists explain that aortic disease impacts women different than men with success rate and how prevalent it is. Do you look at gender also together with those genetic markers when you're looking at the cutoff for size?
A great question, Greer, and it remains somewhat uncertain. We know that abdominal aortic aneurysms in women are different than they are in men. And so we have a different surgical cut point for abdominal aortic aneurysms. 5.0 centimeters is 5.5 in men. And that's for the typical atherosclerotic type of aneurysm. The data on aneurysm size and risk of dissection in genetic aortopathy is far less clear. And for instance, in Marfan syndrome, the prevalence of dissection is equal between men and women. Whereas in non-genetic aortopathy, we see men having a larger percentage of our total number of dissections, like 2/3. So I think the jury is out in terms of the relationship between gender and how precise we can be with recommending, say, prophylactic surgery. Right now, it's not a consideration. If you have one of those genes where we know the risk in the family is really high at 4.2, it won't matter if you're a male or female. We will be making the same recommendation.
I was one of those people because I dissected at 4.3. I still had an arch aneurysm at 4.6 after I dissected, and 6 months later at Cleveland Clinic had a second open repair at about, I think I was 4.8 at that time, so under the normal 5.0 line. Hey, one of our aortic athletes, Mindy, she said, it just feels like this is a black hole of what causes this. And you've gone a long way to dispel that. But I'm wondering about, what about those that don't appear to be genetic? Like, it sounds like the majority of people are not genetic. Is that your guess at this point?
Yes, it is. We think about, so one of the things to think about here is that we've gone a long way in identifying genetic abnormalities that are dominant and have such an impact on aortic biology that they cause aneurysm and dissections in a fairly large number of affected individuals. There are very likely to be genetic abnormalities that don't have a dominant effect. They have a secondary effect. For example, if you have high blood pressure and one of those genes, you're more likely to dissect. Or if you're a smoker and you have one of those genes, then you're more likely to dissect. So that the effect size of the gene on the condition is moderated through other mechanisms as well, with hypertension and aging being important ones.
So one more question, then I'll turn it back to Greer. Aortic athlete Bruce, who happens to live in Ann Arbor, he's one of your neighbors there. asked, what about generation skipping? Is that a thing? In other words, you talked about other factors coming in. Does it appear in one generation and not in the next generation, and then in a following generation, or not?
So it's possible that it could happen. Clearly when we see even these dominant genes, not everybody in the family has the disease. Their aorta stays normal. So what's going on with that? And that has to do with how the gene is interpreted by the body. It may have to do with other factors in their life, hypertension, et cetera. So it's conceivable that a gene could affect one family and then skip and then be manifest again in the next generation. But it's also possible that next generation is a separate mutation. It wasn't a gene that was passed. It was a mutation that happened as the individual is being formed.
You say that you're discovering new genes and things to look for or markers all the time. Do you ever recommend, for example, I'll just make it personal, my genetic testing came back clear, but they told me that as they discover more, they don't kind of reach out and tell you that. Do you ever recommend, especially with people who have children or potentially siblings, to sort of redo the genetic testing after a certain amount of time because of the change in the discovery and the change of the knowledge, just for people in their family to have more information?
So it's a great question, Greer. I think part of it depends on how long ago a person was tested, right? So if you were tested 10 years ago, we might have been looking at 15 genes. And if you get tested 3 years from now, we'll probably have 30 to 35. Uh, and if there's a family history of aortic disease and we don't find a gene, then we end up recommending imaging for all first degree relatives because we're not sure who might get it, right? And if subsequent testing would allow sort of a more precise way of dealing with the family, that might seem like a good idea. So I tell my patients, every 5 to 10 years, let's have this discussion to see if we think that the number of genes that have come forward, and also by then there will be additional accumulation information about the family that may be helpful in sourcing that it's time to retest.
So I can change the topic slightly and ask another question from one of our aortic athletes. And Laura asks about stiffness in the aorta and how is the stiffness of an aorta tested and why is it tested?
A great question. And her question, I think, gets at a much larger thought, and that is if we think about risk for aortic aneurysm and aortic dissection, we're stuck on just size, aren't we? And isn't there so much more information that we could get? And the answer is yes. There are sophisticated 3D and 4-dimensional imaging tools that allow us to look for tortuosity of the aorta, how long is the aorta, whether the flow inside the aorta is laminar or is it circling like a tornado, how stiff is the aorta and what risk does that have. These techniques are very complex to perform and they're very expensive to try to roll out to the general population. One of the risk factors for dissection, of course, in aneurysm is aging. And we think as the aorta ages, the number of the elastic elements in the aortic wall gradually goes down a bit. That creates more stiffness, which leads to an interesting thing where blood pressure tends to rise as we get older, as the arteries get a little bit more stiff. And that probably also leads to a slightly higher chance of aneurysm and or dissection in the right circumstance. We can measure stiffness, but is it a reliable indicator for risk? Not at this point. And hopefully as we get better with our imaging, we'll have better answers for such a great question.
So I think looking at your bio and University of Michigan in general, you have been involved with IRAD, the International Registry of Aortic Dissection. Have I got that right? And what is that? What, how does it, what role does it play, and what role have you played with that? And the related question is there like a confluence of IRAD with the new genetic work that's been done?
That's a great question, Jack. The International Registry of Aortic Dissection was founded more than 30 years ago. And I co-founded it with two other cardiologists. And because aortic dissection is a rare disease, if you try to just study it at a single institution, you don't get enough information quickly to really understand how is it presenting, who's getting it, how is it being managed, how is it being followed, how are patients doing over time, what are the risks of surgery, things like that. And so 30 years ago, we wanted to try to create a collaborative where we would combine data from multiple centers in order to try to learn more quickly about how aortic dissection presents and how it's managed and how patients do. And over the years, we've now got 60 centers around the world in 15 countries. We studied about 18,500 patients with aortic dissection. And we are asking questions of the database that we have here at the University of Michigan to try to continue to improve our knowledge with hopes that that will lead to changes in care. And the IRAD investigators are absolutely determined to try to push the boundaries for better care. The genetic studies that I alluded to sometimes come from single institutions like ours. Diana Malowitz at the University of Texas in Houston has created something called the Multoclonal Collaborative. You saw one slide related to that. That's a large group of centers in the world that are collecting patients with aortic diseases that are thought to be genetic, looking at specific genetic connections with risk. There's a wonderful registry led by Shane Morris in Texas called Clarity, which is looking more at young people with aortopathy. And there are multiple genetic registries in the world, some of the most famous in France, that are trying to unlock the keys of genetics and aortic disease and aortic dissection risk.
Dr. Diana Milowitz is a friend of aortic athletes. We've interviewed her, and in fact, she took my blood pressure at mile 18 of the New York, when I jogged the New York Marathon last November. And so she's a great, really a great, like you. And thank you for creating IRAD. Thank you. When I dissected, my doctor, Dr. Ron Miles, shout out to him at Aspirus Wausau Hospital in Wausau, Wisconsin, 2 hours south of here, related to me a lot of data and information from IRAD before I went in for surgery. So I want you to know that we're grateful to you for that.
Absolutely.
You know, I have a deep passion for this problem. It's rare, it's highly lethal, it's poorly understood. It's in my soul, Jack. I absolutely am driven to try to do whatever I can in my remaining life to try to get more knowledge, more possibilities for patients who are at risk for it or have it. And for me, it's been a great pleasure to be part of a global community, patients, families like you, as well as scientists and doctors and surgeons. We're pushing back the frontier of a very important condition. So it's a pleasure for me to be involved in it.
Well, one more, and then I'll turn it back to Greer. You've done some research recently on bicuspid genetics. We have aortic athletes. We really run the whole spectrum of aortic disease. So we have people who merely have a bicuspid aortic valve. Some have aneurysms. Some are aneurysms post-repair, like Brad Way in our group. And how do you have? Are you beginning to have an inkling of how bicuspid genetics are the same or different from syndromes like Marfan? I mean, are there similarities?
So the answer is no, they're not too similar. We are in the very Neanderthal stage of understanding the genetics of bicuspid disease. We test 500 patients and we find a few that have a gene that we think is involved. So it's a much different situation. It's not a dominant set of a few genes that cause bicuspid valve disease and or associated aortopathy. So right now we sort of treat bicuspid aortopathy like we would any patient with aortic disease. Thankfully, the aorta of patients who have bicuspid valve disease does not appear to behave as dangerously as some of these unique mutations that we talked about earlier. Tend to do better, and with great blood pressure control and surveillance, pretty unlikely to dissect.
Another question we have from aortic athlete Angie, who's 75 and has a dilated root of about 4.3, but has been stable for a number of years. She did also have a genetic test and has the Ehlers-Danlos gene variation. And I think her question is direct to her, and I'll make it more general. She said she's been suffering from major post-exercise fatigue and was wondering if the fatigue could be associated with the variant. And a more general question, I'd say, if you have a variant, do you have different symptoms, or do you still sort of present the same way? Does it make you feel different in any way?
Well, she's asking a question that is really quite vexing for us. Our work in the Marchand Foundation, we see fatigue as a major concern and problem, and it's really poorly understood. And it represents part of the social science that we have to try to unlock. And I dare to say we're not very good at this yet. It's a common complaint among patients with genetic aortopathy. We think there's probably a basis for it, but I can't tell you right now what that is. Also, I'll be honest, as a general cardiologist dealing with patients of all ages, if you ask me among your patients 75 years or older, how many of them express a symptom of fatigue, it's common. And so then the question, am I ascribing my fatigue to a known gene, or is it just that, I've lost a little bit of my motor at my age? I don't know. And, we need to get better at that.
On another exercise question, I'm going to combine two that we had. One aortic athlete asked, what are the top 3 exercise dissection athletes should avoid? So if they've already dissected. And then we get a lot of questions about core exercise because, you can tend to hold your breath when you're working your core with Pilates or something like that. Or is it okay if you're still breathing through it?
And those are great questions. Just like the fatigue question, the degree of depth of science to guide activity among patients with aneurysms and or dissections is not very great. We end up using indirect information to provide advice, which is pretty imprecise, I'll say. We know that if you ask 35 patients who've suffered an aortic dissection, what was the activity you were doing right before the dissection occurred? There's an overrepresentation of vigorous exercise, chopping wood, lifting a refrigerator, things like that. Those are types of exercise that involve the Valsalva, where you're straining your abdominal muscles. And we know from studies of what happens with blood pressure that when you do those kinds of exercises, the blood pressure spikes quite a bit. And we think, well, maybe that's the trigger for an aortic dissection. If you're lifting a heavy chair and your blood pressure goes from 120 to 200, is that stress on your aorta enough to cause a tear? We think that's probably a mechanism sometimes. but the relationship is not perfect at all. And so what do? I tend to say to my patients, if you can avoid heavy isometric exercises, especially the kind where you really strain your abdominal muscles, that bumps your blood pressure a lot and quickly. I tend to suggest that you avoid that if you're willing to. I think moderate aerobic exercise is wonderful for patients, and generally I think is really good for patients with aortic disease. When we exercise regularly, we feel better. In general, our blood pressures are lower. We're more fit. Um, so I like exercise both in aneurysm patients and dissection survivors, but I do try to get them to avoid super heavy lifting and things like that. I'm not a fan of pull-ups or push-ups where you're essentially lifting your whole body weight suddenly or half your body weight when you do push-ups. But at the end of the day, because the science is somewhat imperfect, I think it ends up being an informed patient decision. And I give them the information that I have, but I also say to them, this is your life, not my life. And who am I to judge what you do? When we surveyed some years ago, we surveyed the IRED investigators and said, what's the maximum amount of weight that you recommend your patients lift, right? I think we gave them from 0 to 80. Um, and the range of response was everywhere from 0 to 80. And some people wrote back and said, I don't give them any restrictions. I want them to be active. I think that probably illustrates you got 50 or 60 aortic specialists saying, I don't know. This is what I do. But if you're a regular weightlifter, you may breathe through lifting 80 pounds, whereas you're not such a regular lifter like Kim Eagle, you might strain at 40. Um, and I think for me, at least, based on what I know, the sudden straining where the blood pressure pops is a rational argument to avoid that. But I have weightlifters in my practice who send me a letter when they win a competition, and I congratulate them and say to them, I respect that you're living a full life, and who am I to tell you not to? That's not my job. My job is, this is what we know. This is what we don't know. And you and I are working together to try to give you the best chance at health. And I respect your decision. It's your life.
Going back to the fatigue question for a second. Well, first of all, I want to say I dissected while drinking a Pabst Blue Ribbon beer at a fire pit in the middle of winter outside here. I had been snowshoeing earlier in the day, but so I blame the Pabst Blue Ribbon.
And to be that, yeah, a Miller, you wouldn't have had a problem.
Yeah.
On the on the fatigue side of things, we hear a lot about the beta blockers, of course, as the cause of that. And some people find changing prescriptions from one beta blocker to another reduces their fatigue. I want to raise a different issue. When we surveyed aortic athletes when they first joined our group, 70% of them are afraid to exercise. So the vast majority, and they are becoming detrained, after diagnosis or after dissection, and I always say that the number one activity when we surveyed our aortic athletes that the aortic athlete does is walking. And walking can be nice and slow to get started, and little by little by little, people can incrementally increase their pace. Sometimes they find themselves jogging or walk running and stuff like that. So talk a little bit about how do we overcome the fear of exercise?
Well, yeah, thank you for that question. It's a $1 million question. First of all, we've as you know, we've just finished a study looking at dissection survivors, which looked at the safety of moderate exercise, aerobic exercise, and our data is consistent with my sense of it, and that is that it's safe to do moderate exercise, and I think some exercise is way better than no exercise. The medical community, when it's faced with areas of uncertainty, tends to shut down and say, don't do that. Kim Eagle does not recommend that at all. I don't. I want my patients to walk. If they want to do light jogging, that's absolutely fine. I think that's really important. When we surveyed dissection survivors, a lot of them were afraid to exercise. A lot of them were afraid to have sex again, which I say that's crazy. You know, sexual intercourse is a wonderful form of life and exercise, and one shouldn't be afraid of that. Um, so exercise, I think, is important. It's, in my practice, recommended. I would like my patients to do 30 minutes of some kind of movement every day, 5 days a week. If they want to do a little more, that's great. I do think with aortic disease, warming up and cooling down is smart. That allows the blood pressures and the heart rate changes during exercise to be a little smoother. Um, and, you know, obviously aortic athletes are exercising, and I commend you for it because I think overall it's beneficial to your health and certainly to both our physical and our emotional health.
Greer, I'll turn it over to you. Why don't we ask two more questions, and then we'll close this out.
Well, I was going to ask a question that was sort of a little bit bouncing off the question we talked about earlier with air quality, but what about the heat? It's getting really hot out, and I'm like told, don't walk your dogs, right? Your dogs can't go out. But does heat impact people in a significantly different way when they have aortic disease, or should they be avoiding the heat?
Well, it's a great question, and my answer to you is going to be based on the fact that most patients who have aortic disease are on medications that lower their blood pressure, right? And so if they then go out in the heat and exercise, it's much easier for them to become dehydrated. And therefore, it's much more likely that they're going to have either a fall or a faint. And so I want them to be very careful in that regard, and prefer they exercise early in the day, late in the day, stay hydrated. And it's more the fact that because they're on medications that lower their blood pressure, they're more sensitive to periods of dehydration, whether it's from heat or the flu or vomiting. And we need to try to, I hate it when patients fall. That's a very dangerous thing.
And I guess a really broad, maybe last question is, where would you want to see the science go? Like if you had your pick of any study to do with respect to aortic disease, where do you think, the biggest runway for the to help the most patients would be?
Well, ironically, Greer, um, finding the population at risk is the holy grail. And that's typically most patients who are going to dissect have some level of abnormal aortic size. Even if it's mild enlargement, it's not quite in the normal zone, right? And Jack's an example of that. 4.3 or 4 is not particularly big, but it's nowhere near normal. We have in our midst right now a screening tool that's available to all middle-aged and older Americans, and it's called a coronary calcium score. We use it actually for the purposes of finding early coronary plaque that will affect how we manage cholesterol, for example. But that brief CAT scan can find aortic enlargement, even if it's mild. And when that happens, I would encourage our audience to say, you know what? Curiously enough, even though that wasn't the reason I had my calcium score, I got to make sure that my doctor sees that on the report. And maybe that will cause me to say, my dad's sudden death, maybe it wasn't a heart attack. Maybe it was actually an aortic dissection. So that is something that I would like to see rolled out because it has the greatest chance right now of finding patients at risk who don't know they have a problem.
That's great. Thank you. This
Well,
was fantastic.
Dr. Kim Eagle, we're gonna consider you a friend of aortic athletes after this talk. What a pleasure to meet you and to and really thank you for all your years of advocacy and research. We're just I always say that aortic athletes is an empty gong. We can do all the peer-to-peer support in the world, but if we don't have sound science behind us, we're just whistling in the dark.
Well, I want to commend you. I think that the fierceness with which you advocate for education, overall health, exercise, is helping us overcome some of these hidden fears that unfortunately both patients and providers have. And that's really important. You know, I want you to be fierce in advocating for more knowledge, more reassurance about movement, and challenge people like me to continue the fight, to make the science work for patients and families more fully.
Well, that's right on about patient that we have to self-advocate. We didn't ask the question. One aortic athlete said, "My doctor told me never to lift more than 30 pounds, but he told me push-ups are okay. I don't get it." So
And he's right, and he's acknowledging the fact that there's a lot of ignorance among providers who are not knowledgeable. And so the way they hide that is just to say, don't do this. And unfortunately, that's just not right. And your group is a heavy voice to try to fight against that.
Yeah.
all right. Well, Dr. Kim Eagle, thank you so much for talking with us today. And Greer, we'll see you next time.
Sounds great. Thanks, everyone.
Thank you.
Bye.